So Ellen, thanks a million. And, I just, can I advance, Ellen, or you?
Nope, you'll just have to say next slide and I can advance
Next
them
slide.
for you. Sure.
Yeah. I'm working under a handicap, so I'm sober. Just bear with me, everybody. These are my disclosures. And next. So let's, audio. You got a gift, Eric. You got a gift. You're a special guy. And, when Eric calls, I listen. So anyway, next. So the PowerPoints here that, Dr. Braven is a lot smarter than me and better looking. Scope repair burns no bridges. We're talking about the myth of the crescent tear, oblique reduction, how the subscap holds a key and how grafts work. Next. And partial repair can reverse pseudoparalysis. We're going to talk about force couples, the subscap and the comma tissue, and how margin convergence is a lost art. Next. And so who can we help with a scope repair? If someone has, you can just keep clicking there, Ellen, you'll see the absence of escape, no significant arthritis, erosion of the acromion, clicking, and click. This is when I dial 303 Seidel, click, right? So next. And we're talking about force couples. So, the good Lord made it so they only need a business end of your cuff for it to work. And the upper subscap and lower infraspinatus, or the business end of your cuff, they provide a stable fulcrum. Okay, next. And in our lab here, where I work, we found that if you cut the supra and infra in a rat, you repair just the infra, the gait is restored just as well as if you repair both supra and infra. Next. So the supraspinatus is humeral head compressor, not a depressor. The depressors are the upper subscap and the lower infraspinatus. As Eric would say, that's where the ball game's played. Next. So the supraspinatus does very little to depress. So we're going to work about the depressors, which are the upper subscap and the infraspinatus. So next slide. So this is the cable. This is really the business end again of our rotator cuff. That's the upper subscap and lower infraspinatus. This is where we're going to confine our attention. Next. If you can get, just like Dr. Burkhart's picture here, in the suspension bridge, there's two key points fixation. That's how God made our shoulder. So there's a very, very important part of our cuff where the biomechanical stresses are principally concentrated. Next. And this is what the cable looks like in vivo. This is usually as the older patient gets, the more one-defined it gets. Next. You're doing a great job, Ellen. I'm going to send you a little bonus check. So one of the themes tonight is I'm an arthroscopist. I'm minimally invasive. I don't do lat transfers, but I do other things. So the lost art, I think, is tear reduction. We're talking about how we can mobilize these large cuff tears, release the inferior capsule sometimes, and we're going to excavate the cuff from the acromion. I think margin convergence is a lost art because we have so many people selling anchors, double row, triple row. I think we've lost the art of tear reduction. Next. So I'm a lateral to Q person. I respect beach shear, especially for cuffs, but this is the way I was trained, the way I learned. And I use these three portals. You can keep clicking there, Ellen. And I promise I'll fix the next talk because the next talk's a lot longer. It has some funnier videos too. Next. And what I do is I release, a couple of releases I always do. I release the coracohumeral ligament, but I'm careful not to injure what I call the comma tissue. We'll talk about that in a minute. Next. And then I go up top and I release all the scar to the acromion, to the spine of the scapula. And I don't do what we call interval slides because I take this vascular tissue and I think I make it worse. So I don't, and there's Korean literature to support this contention. Next. And then I look for what limb is mobile. And I think that U shapes are very rare, but most of the time you'll see a mobile limb and you have to reduce it to where it belongs, usually oblique reduction. Next slide, please. So we were taught for years that a supraspinatus footprint is very wide. And we learned, you can click, Ellen, that that's not so true, that the lateral supraspinatus footprint, next slide, is only about 1.3 millimeters wide, which means that every time you see this more than 1.3 millimeters of lateral footprint exposed, there has to be a posterior element, usually sometimes anterior, but there has to be a additional component in the supraspinatus. So next slide. And you click the videos too. So when you see what we call a crescent tear, it's not really crescent because one limb is usually mobile. You can click the below one too, Ellen, thanks. So I'm a big believer in oblique reduction. Next slide. I think we've lost the art of oblique reduction. This is how tears belong restored. They don't always deserve a double row because you have to get that side-to-side component. I think we've lost the art of that. So when I see dog ears are done, that usually means they're not reduced. When you know your tear is reduced, you won't have a dog ear. Next slide. So this is what we do, most of us, double row, but I don't do that. Only in acute tears will I do double row. Next slide. And it's a whole can of worms, and I'm sure we'll have time maybe later on for questions. Next. So you have to play a little sleuth work and say, where does this tear belong? So hit this clicker. So most of the time, there's no a mobile limb. We got to figure out where it belongs. Next, please. So this is what happens. There's usually a mobile limb. Next slide. And we got to figure out where that belongs reduction-wise. Dr. Burkhardt, who's been the pioneer in this, even in his writings in 1999 or so, says that tendon-to-tendon healing is important and margin convergence only versus tendon in the bone. Next slide, click. There's no difference. And this is Steve Burkhardt's writings. I have a good friend, Craig Morgan, doesn't use any anchors now. I think that's a little too far, but I do think that there's some wisdom in we've lost side-to-side repair. Next. So that's not what I do. Next slide. So what I do is find the oblique rim, click, and then I'll obliquely reduce it. And next slide, Ellen. And this is what we work hard to do, is to get that reduction, right? It's like reducing a fracture. That's what you want to see. Next slide. Now the subscap, you haven't seen it, but it's seen you. In our series, we have over 90% of our massive tears that subscap tears. Next. And this is the edge of the subscap. There's something that God gives called the comma tissue. And you click it, Ellen. We did a study in our lab, Eric, that the comma is actually 50% SGHL and roughly 50% CHL. And that's going to tell you where the subscap belongs. But we save this comma tissue because, next slide, it gives us something to sew to. Click. So the comma tissue is really not only part of the superior cable, the inferior cable, but it also, if you look at the arrow, gives me tissue to sew the infraspinatus to. So next slide. I am always careful to save the comma tissue. Okay, click. And it restores our cable. Next slide. And if those of you don't use a 7-degree scope, please, for your subscap, it makes it much easier. Next slide, please. To give you an idea what it can do in terms of reduction of the tear, after I mobilize the comma tissue, there it is. It's a lot closer to the infraspinatus. Next. So I can go up top and sew. Now look at this big hole here where the subscap is torn. You'll see a huge gaping hole. Next slide. And once I fix the subscap, Eric and Jonathan and Rachel, whoever's on the phone, look how much smaller the hole is just by fixing the subscap and advancing the comma tissue. Next slide. So then I go up top and I sew whatever is left. Now, there's some studies that this works about as good as anything. Next slide, please. And the SCR has maybe realized tissue doesn't have to always be the greatest quality. And then I'll sew my comma tissue to the infraspinatus and get usually most of the time most coverage. Next slide, please. So I finish my repairs, Eric, with tape, and I keep the footprint usually unscathed. Next slide, please. And I will tension the tear with tape and get, you're not looking for 100% coverage, you're looking for mostly covered. So you can look something like this. Next, please. And you won't always get full coverage, but if you get the infraspinatus and the subscap fixed, I'm no God-given, I'm no Buddy Salvo, but I got a lot of happy patients out there. Next slide, please. I keep the footprint. This is a double row that failed. I came to my office. The footprint is, this is a anchored graveyard. There's a very little tissue for the cuff to grow to. So I think the footprint is sacred ground. Next slide, please. So you don't need full coverage. Steven Snyder, who I trust, just like Eric, an honest guy, you can get a mostly covered cuff. Next. And Dr. Snyder has given us the whole concept of the crimson duvet, will microfracture the tuberosity, and you'll get fill-in. And I've seen it myself from his work, actually. Next slide, please. I will sometimes use the biceps tendon, and many people are now using the biceps as an SCR equivalent. That's a good option. But I'll use it, whatever tissue is available. Next. And I will use microfracture the tuberosity. I'll use tape. I'll use ripstop sutures, whatever it takes. And I'll leave my margin convergence sutures long. Next. And what I'll do, Eric, is I'll incorporate that into my lateral anchor. So you see a cuff tear like this, you say, okay, call the priest. Well, let's take our steps. If you do margin convergence, next slide, and know where the tear belongs, and I'll start reducing the tear, and all of a sudden it starts being covered, and I'll leave these sutures long, and I'll incorporate that into my lateral row. Next slide. And I'll tension it, so this is what it looks like after a microfracture tuberosity, leaving the tuberosity unscathed. Next slide. And this is what it looks like at the end. So mostly covered, not fully always, but mostly under minimal tension, nature abhors tension. Next slide. And this is what we look like. And again, I'm not hitting them out of the park, all these cases, but I have a lot of happy patients. Thank be to God. Next slide. If you know where it belongs. And sometimes you get it fully covered like this. Margin convergence, tape, and you get full coverage under minimal tension. Next slide, please. The issue I got with double row is that most of the studies, all the studies I come up with, are on acute cadavers. Now, I will use double row in acute tear in a young person. Next slide. But every study I come up with, John and Eric, are on acute tears. That's not what happens. They retract along the line of pull. So next slide, please. What happens in nature is retraction along the line of fibers like this. Next slide. Click. So I think that a lot of this is industry driven, and I'm sorry I get my Irish up, but it's all about the Benjamins, right? Next slide. And every anchor we use is about $375. Plus, if you tension it too much, you'll get what we call type 2 failure, which is very difficult to fix sometimes. That's due to medial tension. Next slide, please. So when do I use grafts? I use grafts, A, when I don't run out of gas, and B, when the tissue quality is really poor. If I don't get about 70-80% coverage. And Alan Barber is an honest guy, just like Eric is, and he showed that if you use a graft augmentation, you get about double the success rate. Now, at our hospital, we have tough insurers in Philadelphia. They don't pay for these new products that are out there, so I do the old spun. Next slide. I use my own graft, and I put some sutures medially and laterally, and I end up augmenting. And I think it is a good thing in the right patient. Not everybody, and again, depends on my age. If I run out of gas, then I'm like, I think I have most of it covered. It'll probably be fine. Next slide. Now, the SCR has been the explosion, and everyone's doing this. It's a biologic solution. It's a biologic reverse. Next slide, please. And this is one of the first ones I did. This is a Marine, and this has as Jonathan showed, the horn blower. He's going to have a lag sign. Next slide. This is 9 weeks post-op. This is like 7 years ago, Eric. I'm like, there's something to this. There's something to this. Next slide, please. So I use Bill Pennington technique, and this is his technique that he uses push-in anchors, and it's made the technique a lot easier for me, and it keeps the suture salad much more manageable. So I use it. Those of you, we just wrote a book, and his chapters in this, he does a wonderful technique. He's done more SCRs than anyone in the world, I think, Bill Pennington, Wisconsin. And I use this technique. Next slide, and it's worked well on my hands. And this is a patient I had a failed SCR. She didn't want a reverse. She's only in her late 40s, 50s. So I did a revision SCR on her. And thank God, this is, look, as most studies show, the lateral footprint intact. Next slide. She went on and did very well with this Pennington technique, push lock anchors, double row laterally. Next. So if you look at the results of SCR, depends who did it. Mihata, incredible, ASCS score is 93. I have not done that well. I've done like 22 of these patients. My results are mixed. But Bull Pennington has an honest guy, Green Bay, Wisconsin, 82 SCS scores, but he noted a 2.6% increase in the humeral acroma interval, which is encouraging. Next slide. So you got to know when to hold them, when to fold them. If I see a Hamada 4, which means arthritis, then next clicker, you got to, pick your battles. That's when I call Dr. Seidel and get a reverse. Next. For the therapist in the office, we have some lab studies here where I work showing that immobilization helps rats not only healing, but also diminishes inflammation. So I go real slow. I don't start PT till 3 months after SCRs and my large cuff repair. So next slide, let's just talk about the results. Buddy Salvo's group, partial is as good as full. Next slide. And in our own massive repairs, we had Penn scores of 70, not quite as good as 85, but this was a survey I did a few years ago, but the patients were happy. Next slide. I only use 1.3 anchors. So in summary, partial repair can help a lot of patients. Look for the subscap, question a crescent tear. I use double row for acute tears. I use grafts. I use SCR unless there's arthritis. And more invasive options should be the last resort. So for the audience, what would you like? Next slide. For your loved one, do you want this or would you like this? Next slide. This is my Glenosphere prep. All right. Anyway, thank you. Next slide. Thank you, Brother Eric. And I'll get this video stuff worked out next time. Thanks for your patience.